Welcome to This Week in Emergency Medicine. This week we're covering 10 notable papers spanning cardiac arrest care from the bystander through to neuroprognostication, machine learning for risk stratification at the front door, and the emergency department's role in diagnosing disease that the rest of the system missed. Let's dive in. We'll start with resuscitation, where Resuscitation published 3 papers this week that each chip away at a different link in the chain of survival. Toy and colleagues asked whether a year-long, county-wide bystander, hands-only cardiopulmonary resuscitation training campaign actually moves the needle. Using a difference in differences design across more than 20,000 arrests in the cardiac arrest registry to enhance survival, comparing one large intervention county against 2 control counties, they found bystander cardiopulmonary resuscitation rates rose about 5 percentage points to just over 40% in the intervention region. But once they adjusted and compared against the control counties, that overall effect was not statistically significant because rates were climbing everywhere. The one signal that did hold up was in public locations, where the campaign was associated with roughly a 9 percentage point increase. There was no detectable effect on survival to discharge or neurologically intact survival. The honest read is that community training campaigns may reach bystanders in public spaces, but they are not yet solving the harder problem of arrests at home, which is where most arrests happen. Staying with pre-hospital care, Kreutz and colleagues looked at physician-staffed emergency medical services in the Marburg-Biedenkopf region of Germany, comparing outcomes across more than 1,400 non-traumatic arrests treated by residents, by specialists without critical care training, and by specialists with additional critical care training. Return of spontaneous circulation did not differ significantly between the groups, and response times were comparable. But the critical care trained specialists obtained vascular access faster, gave vasopressors earlier, and had fewer access failures, and in adjusted analysis they had roughly a 60% higher odds of surviving to discharge compared with residents. Survival to discharge rose across the 3 groups from about 12% to 18%. The authors are appropriately cautious. This is observational and hypothesis-generating, and case mix and referral patterns could easily drive some of that gradient. Still, it points toward procedural efficiency, not decision-making, as the plausible mechanism. The third resuscitation paper takes us into the resuscitation bay itself. Kim and colleagues report a pre-planned secondary analysis of the augmented medication cardiopulmonary resuscitation trial, in which arterial lines were placed during ongoing cardiopulmonary resuscitation and blood gases drawn at 10 and 20 minutes. Among 251 out-of-hospital arrest patients, about 37% achieved sustained return of spontaneous circulation, and higher arterial oxygen tension at the 10-minute mark was independently associated with sustained return of circulation, with an exploratory cutoff around 60 millimeters of mercury and carbon dioxide below 70. Notably, pH and lactate showed no consistent pattern. 2 important caveats. The association could not be fully separated from resuscitation duration, since patients who arrest longer look different physiologically, and the absolute outcomes were sobering. Only 2 patients out of 251 had a favorable neurological outcome. This is not yet a reason to routinely draw intra-arrest gases, but it does suggest an arterial line during cardiopulmonary resuscitation gives you more than a blood pressure tracing. Then there is the question of when to stop. In pre-hospital emergency care, Sullivan and colleagues tested the 2025 American Heart Association termination of resuscitation rules in a specific population where the arrest is hypoxic and potentially reversible, choking. Drawing on a prospective multi-center Japanese registry of 248 foreign body airway obstruction arrests in a very elderly cohort, median age around 82, they found the basic life support rule labeled a majority of patients as termination positive, and among those, 2 still achieved a favorable neurological outcome, and about 13% survived to 30 days. The advanced life support rule was far more restrictive, flagging only 12 patients and missing no favorable neurological outcomes, though 4 of those 12 survived to 30 days. The numbers are small and preclude firm safety conclusions, but the practical message is clear. When choking is the suspected cause, apply termination rules with etiology-aware caution. Alongside stopping decisions sits prognostication, and this is where machine learning enters the week. Jin and colleagues, Also in resuscitation, studied 913 comatose post-arrest patients and asked whether adding processed quantitative electroencephalography, specifically suppression ratio and bispectral index available within the first 6 hours, improves early neurological risk stratification over health record data alone. It does. The combined model reached an area under the curve of about 0.88 for poor long-term outcome, significantly better than either clinical data or electroencephalography data alone. With poor outcome occurring in roughly 70% of this cohort, this is not yet a bedside decision tool, and external validation is explicitly needed, but it supports getting processed electroencephalography monitoring on early, rather than waiting for day 3 multimodal assessment. The same theme plays out at the front door in the American Journal of Emergency Medicine, where Lee and colleagues developed and validated machine learning models to flag early deterioration before the first physician assessment. Across roughly 17,500 consecutive adult visits, they combined structured triage variables with transformer-based embeddings of free text nursing triage notes to predict intensive care admission or death within 7 days, an outcome that occurred in about 1 in 22 visits. Their better-performing model achieved a recall of about 77%, with an area under the curve of 0.9. But look at the precision, around 22%, meaning roughly 4 out of 5 flagged patients will not deteriorate. That is why the authors frame this as a ranking and prioritization tool, an adjunct layer of situational awareness rather than an alarm, and they call for prospective shadow testing before anything reaches clinicians. Worth noting that the nursing free text notes carried real incremental predictive value, which is a quiet argument for the clinical value of what triage nurses write. Our last theme is diagnostic difficulty, the patients whose disease hides behind a plausible alternative. In internal and emergency medicine, Koenig and colleagues screened more than 5,000 computed tomography pulmonary angiograms and identified 846 patients who presented with a chest X-ray infiltrate plus clinical or laboratory evidence of infection. Among those apparent pneumonias, about 1 in 8 had pulmonary embolism. And here is the uncomfortable part. C-reactive protein, D-dimer, and the Wells and Geneva scores all failed to discriminate. Prior venous thromboembolism and new-onset atrial fibrillation were somewhat more common with embolism, and wheezing with prolonged expiration was the only feature that argued against it. When your presumed pneumonia does not add up, existing risk scores will not rescue you. 2 other papers round out this theme. In the American Journal of Emergency Medicine, Glau and colleagues conducted a matched case control study of 244 geriatric patients who had both formal delirium screening and a head-computed tomography within 24 hours. Structural brain lesions, most often ischemic, were present in about 56% of delirium cases versus about 38% of matched controls, roughly doubling the odds of delirium after adjusting for dementia and comorbidity. The authors are careful to note this does not establish added diagnostic value beyond bedside assessment, association, not indication for scanning. And in CJEM, Wilkinson and colleagues reviewed over 1,000 new cancer cases at a Canadian center and found that nearly 13% were diagnosed through the emergency department. Those patients were far more likely to present with stage 4 disease, about 65% versus 17%, and their 1-year mortality was roughly 5 times higher. Strikingly, emergency diagnosed patients moved through the system faster, with a median diagnostic interval of 19 days versus 84 in the community, and over 80% of all patients had a primary care provider. The emergency department is functioning as an accelerated diagnostic pathway by default, which is an indictment of outpatient imaging and biopsy access, rather than a triumph. Finally and briefly, in the American Journal of Emergency Medicine, London and colleagues showed that implementing a structured multidisciplinary trauma protocol at an inner-city non-trauma center emergency department cut median time to transfer from 78 to 50 minutes, and time to computed tomography from 90 to 34 minutes, with improved documentation. Mortality fell from about 10% to 6%, but that difference was not statistically significant in this small pre-post cohort. If you only have time for one paper this week, make it the pulmonary embolism and suspected pneumonia analysis in internal and emergency medicine. It targets an error you will make this month, and it tells you that the scores you reach for to reassure yourself simply do not work in this population. Here are the key takeaways from this week in emergency medicine. First, in patients who look like pneumonia, pulmonary embolism is present in roughly 1 in 8 of those who get scanned, and Wells, Geneva, D-dimer, and C-reactive protein will not sort them for you. Clinical suspicion has to do the work. Second, termination of resuscitation rules should be applied cautiously when choking is the suspected cause, because the basic life support rule missed patients who went on to good neurological recovery. Third, community bystander cardiopulmonary resuscitation campaigns showed benefit only for arrests in public places, with no detectable effect at home or on survival. The home arrest problem remains unsolved. Fourth, machine learning models for early deterioration and for post-arrest prognostication are performing respectably, but with precision around 20% at triage, these belong in shadow testing and prioritization, not in clinical alerts. And fifth, when older patients screen positive for delirium and have a head-computed tomography for other reasons, structural lesions are common and roughly double the odds of delirium, but that is not a reason to scan everyone. That's your roundup for this week in emergency medicine. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And a quick rating on Apple Podcasts or Spotify helps other physicians discover the show. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.